Good afternoon, everyone, and welcome to our panel discussion this afternoon, Health and Wellness, a Vital Component for National Productivity and Economic Growth, brought to us today as part of the activities for National Productivity Awareness Week, sponsored by the National Competitiveness and Productivity Council. I wish to welcome all of you who are joining us live and those who have joined us virtually to what I hope will be a very exciting session with an amazing and distinguished cast of panelists. My name is Lydia Atkins, and I am a Senior Technical Officer with the Caribbean Public Health Agency, working within the OACS Health Unit as we partner on strengthening and advancing the health agenda of the OACS member states. And I am honored and delighted that today I get to moderate this session on health and wellness, a vital component for national productivity and economic growth. I'm sure many of you in our live and virtual audience are already familiar with the need and importance for strengthening health systems to actual achievements of goals. And in fact, the SDGs, which now guide us for the next several years in our health system action, and integrates action across several goals as it recognizes that development must balance social, economic, and environmental sustainability if we are to eradicate poverty. So the question today is, how do we position health as a driver for economic growth and national productivity? What are the pathways to actual implementation and activation of health systems together with their subcomponents? And how can we really enforce that at a national level? I think one of the goals and visions that we have all signed on to is universal health coverage. And so today I hope that among our distinguished panelists, we will at least hear a mention of two of UHC and see how health system strengthening can serve as a driver for economic growth and be a key component for achieving universal health coverage. I also hope that today we can have an explicit discussion about the need for vertical programs and achieving goals in specific disease conditions like non-communicable diseases. And they're all important. But at the same time, how is it that we do this in a way that enables a generalized and horizontal structuring of our national health system? I also hope that today, with the diversity of our panelists, that we are able to have a discussion about different sectors and their engagement, the public sector, private sector, academic institutions, the importance of the labor force, and how can all of us coming from our very different perspectives work together in a collaborative model for pivoting health as an economic driver in our society. I hope that this conversation will not forget the people that we are supposed to serve, the public, and what is the role of community engagement, community participation in positioning health as a vital component for national productivity and economic growth. How do we balance concerns for general health and economics during a pandemic? The COVID-19 pandemic has given the world a once-in-a-generation opportunity to advance broad-based health and economic development. And how do we reprioritize health to rebuild our economies? I hope that we will have a dialogue that stimulates all of these discussions and that your incredible wealth and experience and expertise would allow for a very provocative engagement, and not just in agreement, but we can challenge this discussion in how it is that we are to pivot health as a driver for economic growth and development. I'm really honored at the quality of our panelists today and delighted to invite them at this time to give their opening statements. And we will start off with Mr. Nahum Jabatis, and I am honored to introduce him and to speak to him today publicly as a mentor with extensive experience in the public sector. It is under his leadership that many reforms were realized in the HIV management program, epidemiology and health information units of the Ministry of Health. I fundamentally believe that irrespective of how we in the academic sector or the global or regional level discuss health system strengthening, or how it is that we seek to leverage health as an economic driver for natural growth, it is actually on the ground that population or defining our population is a key component of that discussion. Nahum Jabatis has initiated and participated, in many important initiatives in his professional and social life, which has earned him national recognition as he has contributed meaningfully to the improvement of health, culture, and the overall well-being of the St. Lucian people. He holds a Master's of Science degree in Medical Demography from the London School of Hygiene and Tropical Medicine. He is an adjunct professor with the Monroe College and IAU Medical College, and has lectured many students in public health, community health, and epidemiology, as well as biostatistics. It is under his esteemed leadership as director of the National HIV/AIDS Program from 2003 to 2012 that St. Lucia successfully implemented its first national strategic plan for HIV/AIDS and introduced treatment and care for persons living with HIV/AIDS free to the cost of the client, and for the first time in 2010. The Mother-to-Child Prevention Program was established in 2007, and the last case of vertical transmission of HIV was seen in 2009. He is not only a seasoned public servant, but he is also an accomplished musician and songwriter. He is currently the coordinator for the performance-based financing program with the Ministry of Health, with responsibility for diabetes and hypertension, and as part of the Health System Strengthening Project of the Ministry of Health since 2020. I now hand the mic over to the medical demographer extraordinaire to lead us, or to set the tone for us on our discussions today as it relates to health and wellness, a vital component for national productivity and economic growth.
Thank you very much, Ms. Atkins. You gave me so many hats there, but I think you are quite right in having us to begin with the setting the tone with respect to the population, and that is because the population represents the human capital aspect of things, and for both national productivity, which we define typically as measured in terms of the gross domestic product per capita, and also the economic growth, which we look at in terms of increasing an economy's ability to provide the wants and needs for those who belong to a given society. I think the population, the wellness of that population, is therefore paramount for both the sustained national productivity and the economic growth that we are about to discuss here. So I always like to start off by numbers, the number of persons in the population, and then the latest estimate we have, for example, in St. Lucia, that it is about 182,279. But just looking at the population itself, without looking at the different sectors in the population, can mask some of the true issues, social issues, economic issues, and all of the other issues behind the actual characteristics of that population, how it can contribute significantly or not to our economic development and productivity and so on. So what I will attempt to do, so for example, just in terms of distribution, we can look at the population under 15 years, for example, to define children, and we can look at population 15 to 59 years to define the productive sector, or the most productive sector of the population. And then we can look at population 60 years or older to define the older population. What we have found, or what has been happening over the last 3 or 4 decades, what we have seen is that there is evidence that older persons are becoming proportionately larger in terms of the share of the population. And this is as a result of what we call in demography, demographic transition. And it's because we have seen over those years, first a reduction in mortality, and then followed by a reduction in fertility. So because of the reduction in mortality, we have an increase in life expectancy. So on average, persons live longer. And because of the reduction in fertility, we see less and less, proportionately less persons being born into the population. And so what we have found is that as the persons who are born become older, they survive because of course, the reductions in fertility. And so what will happen to us over the next 20, 25, even 10 years, we would start to see a lot more persons being in the older populations compared to those being born. That was not always so. Over the last 30 years or so, we used to see a lot more births being born. Sorry, a lot more persons being births, live births. And so we saw at the base of the population proportionately more persons compared to the top of the population. So we're looking more like a pyramid. But if you look at the population structure, in terms of a population pyramid, we can no longer define it as a population pyramid. It's now looking more like a population barrel. And this, I think, has significant implications for our planning going forward in terms of economic, social, and otherwise. So that shift in the age structure is going to have significant impact on our economic growth, savings, investment, consumption, labor markets, pensions, and taxations, to name a few. In terms of the social sphere, it's going to have impact on healthcare, the family composition, living arrangements, housing, and migration. And even in the political sphere, it's going to have impact on voting patterns and representation. Now we have seen that demographic transition, which I mentioned earlier, has to do with the shifting of the proportion of the population to the older age groups, has happened simultaneously with epidemiologic transition. Epidemiologic transition is demonstrated by the replacement of communicable disease by NCDs as the more important cause of death. So, for example, in St. Lucia, we have noted that cancers, strokes, heart disease, diabetes, and hypertension have remained among the top 5 causes of death in the country for more than 5 decades. Now, as a developing country, this demographic and epidemiologic transition has been happening at a much faster rate compared to the more developed countries. And so we have now to tailor our responses, both our economic responses and our healthcare responses, to address those issues. I want to just close by touching on some of the priority areas that I think that in view of this shift in the demographic structure of the population that we ought to address going forward, taking into consideration the human capital that I tried to introduce there that we have, and what it should be in the future. So first of all, in terms of the under 15 age group, we should look at maternal and perinatal health, specifically in terms of stillbirths and early neonatal deaths. So even if we have less births, we still have to look at the health of those to ensure that whatever we have in place would provide quality care and survival for children and mothers. There is also the violence and injuries that we ought to look at, specifically assault, homicide, and road traffic accidents. And this is an area that I think we have not implemented enough public health action to ensure the wellness of the younger persons in our population. Then, of course, we would have the chronic non-communicable diseases, specifically cancers, strokes, heart disease, diabetes, and hypertension. We should not forget communicable diseases, and the COVID pandemic is a very good example of that, that we must have sustained action there despite their lower prominence in the causes of death in the country. What this COVID pandemic has also done, so that because we have a much higher mortality from COVID among persons who have an underlying cause. And in our country, it seems to be more diabetes and hypertension, and as well as some of the chronic respiratory diseases. So we have to address all of those simultaneously and in tandem, so that we don't get we stand a much better chance of addressing more holistically the problem of communicable and non-communicable diseases. Mental health, we should also include mental health, because the impact of all of those diseases are definitely going to have consequences. And if we're talking about health and wellness, then definitely mental health has to be among the priority areas. And then finally, I want to mention health system strengthening as the approach to going across all of those aforementioned priority areas. So I think I will stop here now and hand you over back to our moderator.
Thank you very much, Mr. Jean-Baptiste, for setting the stage for us in understanding the implication of demographic changes for health and the economy. And for reminding us that there must be an explicit prioritization on the human capital and tailoring our economic and healthcare responses to address these issues as we seek to address the demographic transition that has allowed for us to see a change in terms of the structure of St. Lucia's population, with what is an increasingly larger, older population, and the implications that this has for us in terms of the shift in the structure with regards to its impact on health and healthcare, in terms of its impact on housing, and infrastructure and migration, as well as its economic impact in terms of savings, spending, and workforce productivity. I think you have, and finally, ending that discourse with regards to the priority areas and the need for us, especially in light of a COVID-19 pandemic, for us to continue to remain vigilant as it relates to communicable diseases, even though they are and making sure that there is sustained action despite their lower positioning as it relates to the causes of death in St. Lucia. And lastly, to begin to stir the direction of our discussion today as it relates to using health system strengthening efforts as a means of positioning health as a driver for economic development. And that allows us to segue into our second speaker for this afternoon, Dr. Christine Lapisse. Dr. Lapisse is an economist at HEU, Center for Health Economics, and she specializes in the area of health financing with an emphasis on costing health programs and disease conditions. For over 25 years, she has worked extensively throughout the region, providing technical support to countries by developing and costing strategic plans for health programs and costing healthcare services and diseases. Her research area also includes the measurement of intangible costs of disease, the poverty and health nexus, and the national health accounts. She lectures undergraduates and postgraduate courses in health economics and has published in several areas, including NCDs and the impact on the economy, tobacco and alcohol taxation, aging, and the role of the state in healthcare financing. I hand over to you now, Dr. Lapisse.
Thank you so much. Thank you. And thank you for the invitation. And good afternoon to everyone. Today I'm going to take a look at understanding the relationship between health and economic growth. And I just want to acknowledge those who worked on the short presentation with me, Dr. Alfred Lafourcade, Ms. Halima Ali Sisbane, and Professor Carl Theodore. And really I'm taking up from the last speaker, where we look more at the theoretical base, where we look at our factors of production and land, labor, capital, but our focus today will be on our capital and the health of our capital, our human capital, and that's the frame that we want to look at. And when we think of that link between health and economic growth, we realize that health has a direct impact on the welfare of the population, and then by extension, the productivity of the population, and then the actual economy itself. And when we look at that, one of a seminal piece by an author, Neil Over, in 1991, looked at that intersection of health and how it impacts different parts of the economy. And we look at the production of goods and services that generate our national income. And we're saying who works, who is it that helps to generate that production? And we are looking at our population. We heard a little earlier about our working population and some of the demographic changes. And then we want to look at that. How do we consider the health of the population when we think about production, when we think about economic growth, when we think about our expenditure, and we think about progressing and expanding our economy? So the key thing is that when we think about labor, our population as an input into the production cycle, we look at the importance then of having a healthy population. When we look at that, we can look at 4 channels. Bloom et al. In 2004 highlighted 4 channels that we can look at where we can see health contributing to an economy and health and economic growth. And one of the first things that they looked at was really the productivity of labor, and that is directly impacted on by good health, the productivity of labor. And then we look at the labor supply itself. And our labor supply will expand as we have a healthier labor pool from which to choose. So that's important there. Then we also look at the skill set, the skills that our population gains from engaging in education and developing their skills. And healthy individuals are then able to attend educational institutions to further their work. And then when they enter into that production cycle, we realize that the savings that they have, savings that they may invest in different things, and that savings becomes a pool then where we can make that available for further investment, intellectual investment, and otherwise. So it is really a cycle when we think about looking at the health of the population. What COVID-19 has done for us is that when we look at that whole theory and we look at the impact on labor and the health of labor itself in the production of goods and services our economic growth, we realize that we look at that at a micro level, where we're looking at labor, the individual, the health of the individual. What we realize here with COVID-19 is that it forces us to take even a more macro view of health and the relationship with economic growth and the economy. And for some of us, we may have heard this term about securing lives and securing livelihoods. And that is a different view from what we were just talking about, that basic theoretical framework where we look at the health of labor itself. We realize that as countries had to respond to this pandemic, it wasn't just simply making sure that sick people got well, but it was also looking at preventing illness. And because of the situation of COVID-19, we realized the wide-ranging impact that had on many of our economies. Some went through shutdowns, partial shutdowns, and different things. And we see that happening in our region. And I just wanted to take a look at the impact of COVID-19 on the GDP of St. Lucia, for example, where we see that there was a reduction in economic growth and in minus figures, and based on ECLAC studies, we see a reduction of some 18%. So we are seeing then that our growth rate between 2019 and 2020, we actually see the drastic reduction. If we take a look at the GDP for St. Lucia, say from 2018, 2.066 billion US dollars, 2019, 2.11, and then came 2020 and COVID-19, and we see that dropped to 1.73 billion with our per capita incomes going down. So that health on a whole, when we think of the relationship with the economy, our moderator mentioned this is a kind of once in a lifetime situation where we are in a pandemic. We realize then that we have to look, yes, at the health of the population in micro level, but then we'll have to learn to adjust and see how we respond in situations where we may have a crisis. So I just want to summarize then, when we talk about the health and the economy and economic growth, it is not a new development. It is something that has been studied for a long while. But when we think about the pandemic situation, it adds another layer of it as we study the impact of health on the economy. And we know that economic growth and development will allow for investments and improving our health status and so. But we also know that we have to have investments in health and wellness that will also improve our economic growth. So we have some bi-directional influences happening there. So I summarize now as we continue into more of our discussion today, and I look forward to it, of the important role that health plays in our economic growth. And I thank you.
Thank you very much, Dr. Lapis, for reminding us of the intersection that happens or that takes place between health and the economy, and how health impacts welfare, which impacts productivity. But also, you're reminding us of the need to view the population as an input into the production cycle, and the need to leverage domestic resources within our population to realize economic growth as we begin to look at health as a driver for economic development, and focusing a bit in terms of how better health promotes economic growth. bringing us back to the discussions earlier with Mr. Jean-Baptiste, our demographer, in terms of first, fewer people being likely to die prematurely with our aging population, but also looking at how the working age population will increase. And I'll hold those back for later for our discussions as I hand over now to Dr. Stephen King. Dr. King is an anatomical pathologist. He is also a co-founder and shareholder of Laboratory Services and Consultations Limited. He is a co-founder and shareholder of Medical Associates Limited, a fellow of the Royal College of Physicians of Canada, and an international fellow of the College of American Pathologists. He practices pathology in his private capacity, and he is one of the architects of the St. Lucia Health Sector Reform Proposal of 2020, the Universal Healthcare Proposal of 2000, the Universal Healthcare Proposal of 2003, and the National Strategic Plan for Health for 2006 to 2011. He is a former chief medical officer and is one of the co-founders and the first chairman of the AIDS Action Foundation and one of the co-founders and co-director of RISE St. Lucia, Inc. He was awarded the Most Excellent Order of the British Empire in 2008 by Her Majesty for his contribution to medicine in St. Lucia. He was an independent senator from 2011 to 2016 and was awarded the St. Lucia Cross in 2018 for his contribution to society. So we've spoken of the role in some of our discourse. We've heard of the need for a role for the private sector. And so I look forward to Dr. King's discussions as he talks to us a bit about health and wellness as a vital component for national productivity and economic growth from his perspective, both in terms of being one of the leading private sector providers in the health sector and in health investment, but also from a development perspective. Because most importantly, as I've spoken to the various positions that he's held, both in the private sector, but most notably his contributions that he's made in the public sector, and his ability over the years of service to keep his hand on the pulse of the patient, who is critical to this discussion if we're going to discuss health and economic development, where our population is a key component of that discussion. Over to you, Dr. King.
Thank you, Ms. Atkins. As a pathologist, I like that. Keep my hand on the pulse of the patient. But I'm really grateful to be with this panel this afternoon. Health is something that's near and dear, I think, to all of us. And I have a little PowerPoint presentation because I think this is so important. And I just wanted to share some diagrams with you and some ideas. For me, it's all about sustainable economic growth. It's not just economic growth, it's sustainable economic growth, which means we have to be intelligent, we have to be innovative, we have to be creative, we have to be progressive in how we make our decisions and our choices as to where we spend our money, how we spend our money, and how we invest. And I think investing in health, I want to make an argument that is a good investment to make. Sir George Arlene, director of PAHO some years ago, made a fundamental point that still resonates with me, that as health, the health sector and health interventions are central for human development. And if we think about it, what we truly live for is to us to develop as individuals, but fundamentally as a collective, as a people moving forward. And then Sir Arthur Lewis, many, many years ago, made the statement that public health is as important to economic development as economic development is to public health. And I think that gets back to a point that I think Mr. Lapetisse was making. I made up this diagram, and it's not novel in any way, but I put it here to make a point. I call this really the virtuous cycle of wealth. And human capital, and we've heard both our previous speakers speak to this issue, human capital is fundamental. Now, you can enter this cycle anywhere you would like, in any one of these boxes, but let us start with human capital. Human capital is a major asset in any economy. And in small island states like St. Lucia and in the other Caribbean states, human capital is probably the most important asset that we have. And we in health, especially when you consider holistic health, we are fundamental to the development of this human capital. But there's also social capital, which is how we cooperate, the team. How do we work as a diverse set of people with diverse ideas from diverse backgrounds? How do we unite on common goals, common challenges, common principles, common vision? How do we move forward together? And it is well known that social capital, 1 + 1 human being in a team working towards with shall we say a common vision, is much more than 2 people. In other words, social capital adds value to that human capital. And there's knowledge capital. And let's be clear, the knowledge bank that we have, not only there's traditional knowledge, there's scientific knowledge, there's ongoing knowledge contributing to this knowledge capital. And all of us must be part of that, as part of the wealth cycle. And of course, there's development and then wealth, and the cycle continues, because as we generate wealth, we can invest more in the capital development and therefore progress. When I was chairman of health sector reform, we started in 1997. In 2000, we produced the health sector reform proposals. And what we put there, I still go back to, because it's well worthwhile remembering. Quality of life is determined by choices. It is essential that we give our people the tools to be aware and to make the most appropriate choices, thus empowering them to experience the maximum quality of life. And this is how I've always seen health care, as delivering this to people. And this is what essentially another way of looking at how WHO has defined health: the spiritual, physical, and mental wellness, which holds or allows us to have a quality of life. I tease my friends, my close friends, that happiness is really a personal decision. It's born of optimizing your spirituality, your knowledge, your decision making. Regardless of your physical situation, you can be happy, but you need to be supported, and you need to understand, and you need to have those tools. And all change begins with individuals, and as such, addressing the holistic health of an individual is fundamental to the economy. But let's get back to the economic impact of certain things. I picked 4 major areas to show an impact, economic impact. I looked at the pandemics, such as COVID-19, specifically COVID-19. And I think we're going to have to document the COVID-19 lessons as we move forward. Just like the UK put out a report today looking at their lessons so far. We're going to have to do the same thing in St. Lucia. But there's no doubt, and I mean, I think, is it Dr. Lapatis? Right? She mentioned about the GDP loss in St. Lucia of 18%. Globally, it's 2.9 to 4.5%. That's almost $4 trillion. But there's also loss of household incomes. And when you think about this, going forward, there's going to be less money to protect vulnerable. There are going to be more vulnerable households. There's going to be more impact on the poorer and more vulnerable people post-COVID. And that brings me to the long COVID. Long COVID is what we of course, we in medicine are looking at the physical and neuropsychiatric condition of long COVID. 1 to 5% of people that recover from COVID are going to have long COVID disease. That is 1 to 5% will have debilitating long COVID disease. All right? We can talk about that maybe. But there's going to be also significant social problems and economic problems going forward. I've mentioned less resources to support vulnerable populations and an increase in the vulnerable population in our country. But also there is the divisions and the undermining of confidence in authorities and in health practitioners that has also happened. That is also going to be shall we say, a poor outcome of long COVID. So we're going to have to deal with all of that. Then one of my favorite is adverse childhood experiences and toxic stress. And there's a beautiful paper put out in Child Abuse and Neglect and looked at North America and makes the point that the annual cost to North America for child maltreatment is $2 trillion. CDC has pointed out that adverse childhood experiences and toxic stress is probably a #1 public health priority. And I want you to stop and think about it. Why is that so? That is so because the data shows us that, look, somewhere around 20 times, in fact, let me back up. What this does, what adverse childhood experience and toxic stress does, it causes functional and anatomical changes in the human being. It creates a state of chronic fear and chronic stress, which has significant anatomical and functional problems. Decision making is impaired, life choices are impaired, people make bad choices. It creates a chronic inflammatory state in people such that the chronic non-communicable diseases occur at a much higher rate. So not only do we make bad choices, but we have an inherent stress situation. So what does that result in? 20 times the rate of incarceration of the normal population, 15 times the chance of being a perpetrator of violence, 14 times the chance of being a victim of violence, 4 times the rate of diabetes, 3 times heart disease, 3 times respiratory disease, twice the rate of cancer. These are people that have 4 ACEs or not. 16% of North Americans have 4 ACEs or more. This is a serious issue. And you can see the economic impact of it. Chronic non-communicable diseases. And I will not spend a lot of time here, just point you to a paper that points out that Jamaica, 18 times the total health expenditure of Jamaica is lost to chronic non-communicable diseases, showing you that investment is well worth it. And WHO has a nice statement on mental health. Every US dollar spent to address anxiety and depression leads to a $4 return in better health and ability to work. I think these 4 areas point out the importance of health and how it impacts the economy and productivity. I use the term universal health care, not universal health coverage, and I'll explain why. Universal health coverage takes me to a point of thinking about national health insurance and financial coverage. Universal health care, as we envisioned it, is a holistic system of integrated and decentralized care focused on primary, secondary, and tertiary prevention. Primary is preventing disease, secondary is preventing the progression of a disease, and tertiary is mitigating the impact of that disease. Okay? How did we propose that to be so? Back to systems, and Lydia, you mentioned it at the beginning, that we should talk a little bit about this. Integrated healthcare providers, public and private providers working together on common challenges to achieve common goals. We looked at 6 levels of health facilities in St. Lucia, level 1 to level 6. All these levels have to work together. And Lydia, you mentioned in a vertical disease management strategies. And we spoke about that as a software, meaning this is the hardware, the healthcare workers, the institutions that are hardware, the software are the policies, procedures, and disease management plans that we have that address primary, secondary, and tertiary prevention of disease and mitigate the impact. And agreed, this is what is needed, and this is what UHC wanted to do. Also, we looked at integrated information and communication systems across the sectors and integrated multidisciplinary teams. So let me give you an example. Say we wanted to address adverse childhood experiences in St. Lucia. That leads you straight. What kind of integrated multidisciplinary team is required to do that? Clearly, you have to be in the community. You need to have community leaders, you need to have parents, you need to have teachers, you need to have social workers, you need to have police officers, officers of the court, the nurses. You need to have everybody on board. Where does a child and a mother enter into this team during an antenatal care visit? Here is where the first intervention would actually happen with a lady who has become pregnant and needs to be supported and needs to be supported so that she can parent, and she has that whole support system around her to make sure that her child, while the child is growing in her womb and while after the child has been delivered, does not suffer adverse experiences. And that is how you grow a great society, and you have economic growth in a sustainable way. Equitable financing was a component of universal health care, and this talks about fairness and supporting the vulnerable. So we said we had to have equitable financing of a defined, universal, accessible package of interventions. Equity means that those that have more give more, and so that they support those that have less. So it's not just a straight premium-based initiative. It has to be beyond that if we are to truly look at moving as a collective in a fair manner, in an ethical framework of universal health care. And then research and innovation for sustainability and continuous improvement of quality. Your system has to progress, it has to evolve for it to be sustainable. That's why I spoke of the innovation and the creativity. That only happens with evidence-based addressing of all interventions, all issues, all systems, constantly being interrogated, constantly being investigated, and constantly being changed to achieve the goals that we want to achieve. My last slide and last statement is this one, which I find useful in every forum. The fundamental cure for poverty is not money, but knowledge. Sir Arthur Lewis. You don't need a lot of money to have a massive impact. Truly, what you need to do is to impart knowledge. I believe that if you have a very good system and you were to actually take, for instance, our response to COVID-19. If you have a fully engaged community, a fully engaged nation, you house to house, imparting knowledge, people will make the behavior change that is necessary to mitigate transmission. And when the time comes to vaccinate, they're already on board for vaccination because they have the knowledge, the information to make the right choices for themselves, their families, therefore their country, or their community and their countries. And so I believe this statement is put forward by an economist is a very correct statement. Thank you very much.
Thank you so very much, Dr. King. And definitely, I think the terminology in terms of having your finger on the pulse was quite appropriate. For this was a very, while short, very rich discussion. I could not stop taking notes. And just wanted to highlight some of the many important things that you would have said during your presentation. And there were two that resonated with me most. And that is that public health is as important to economic development as economic development is to public health. And that has never been more true, I think, than our current situation when we look at COVID-19, the impact that it has had on our economy, and looking at it from a public health perspective, but also looking at from an economic perspective, how important it is in terms of how various countries, depending on their status of development, how richer countries are able to have a more robust response to COVID-19, and the importance of that response to helping to mitigate the impact of this outbreak on our populations. You spoke to human capital being the most important asset that we have, and social capital in terms of how it speaks to issues and unites us on issues, and the importance of social capital in that it adds value to our human capital. And the need for us to document our COVID-19 experiences and to learn from those experiences. But I also think that the need for us to look at COVID-19 as an opportunity, and an opportunity for us to advance some of those discussions that we're having now. And I think it's almost regrettable that we do not have the policymakers in the room, not as part of our panelists, but as part of the audience, because of the importance of all of this rich discourse has for us in terms of some of the policy decisions that would be required for us to begin to realize health as a driver for economic development. And your closing remarks from an economist and our own economist in terms of the fundamental cure for poverty not being money but knowledge. But most importantly for me in that discussion and that salient point that you made is how community engagement can become a critical component for the imparting of that knowledge, and therefore to begin to address the issues that we have in terms of the paucity of information in our society, but also how it is that we begin to ensure that some of the behavioral changes that we want to see realized, that we're able to realize those by community engagement and imparting that knowledge even before the crisis, and not when we are in crisis that we do mass information sharing with the population. And that brings us now to the discussion, to our final panelist on today's discussion, who will, I'm hoping, narrow that discussion information on some of the things that we've hinted at in our discourse today as it relates to non-communicable diseases and the role that this plays with regards to health and economic development. And so I would like to introduce our final speaker before we go into a question and answer session, who is none other than Dr. Shanna Cyr Philbott, who is a proud graduate of the Faculty of Medical Sciences in Pinar del Rio, Cuba, where she completed her Doctor of Medicine degree in 2005, and keeping people healthy and preventing complications of their disease became her mantra. This desire to serve community and to focus on preventative components of medicine drove her to join the St. Lucia Public Service, where she became a district medical officer in 2007. She is passionate about chronic disease prevention and control, and is a graduate of Cardiff University in Wales, where she attained her postgraduate diploma and later her Masters of Science in Diabetes with distinction. Her passion for diabetes management has led to her completion of a clinical attachment with the endocrinology and diabetes at the University Hospital of Wales in 2017, where she considered it a privilege to have learned from excellent clinicians and experts in the field of diabetes and endocrinology. She has been involved in multiple short training opportunities over the years and currently serves as the Senior Medical Officer with responsibility for non-communicable diseases with the Ministry of Health and Wellness and Elderly Affairs. She continues to be very involved in inpatient education and community-based activities aimed at lessening the social and economic impact of non-communicable diseases in St. Lucia. And so I now hand over the floor to Dr. Shanna Cyr Philbott.
Good afternoon, everyone. I just want to count it a privilege part of this panel. I have been thoroughly impressed with the level of discussion by the panelists before me. And quite frankly, I thought to myself, oh, I'm the last panelist. That means I don't have much to say because it's all been said before. But I will try not to disappoint Ms. Atkins and others. I did prepare some things to say which have already been said, and that is great because there is a saying that great minds think alike. One of the things that I wanted to look at is that for years I always thought that the term prevention is better than cure had to do with medicine or had to do with disease. Recently I found out that when Benjamin Franklin penned those words, he was talking about prevention of fire. So an ounce of prevention is better than cure in terms of preventing fires. I want to take that to the whole connection between health and wealth. And I think that is the discussion that we're having, and I was very impressed to listen to Dr. Stephen King's analysis of this whole situation. I believe that in ensuring that we have wealth, okay, in our country, we need to embark upon a multidisciplinary approach to wellness, health and wellness. And that would involve risk factor reduction, monitoring and evaluation, health system strengthening to improve quality of life. And one of our presenters mentioned equity. That is very important because unfortunately non-communicable diseases affect poorer persons even more. So that there is a need for equity. Of course, we know that our risk factors, as we looked over the years, in terms of mortality in St. Lucia, our main causes of mortality would be non-communicable diseases, which contributes an 80% to our mortality. And not just mortality, but disability. Non-communicable diseases contribute significantly to disability and in our working population, unfortunately. And our risk factors, we noted that our risk factors for non-communicable diseases, the 4 major risk factors, are on the rise. In our surveys that we've carried out, we realize that obesity, especially in our women, is at an all-time high. We also have increased sedentarism or decreased physical activity, and those are significant risk factors for cardiovascular diseases, which are #1 cause of death in the country. Now, it was Ralph Waldo Emerson who stated that our first wealth is health. And I've always heard it, and I think there's so much truth to that as we sit down and discuss today with economists and our health personnel. A person who feels ill, generally, let's think about it. A person who feels ill tends not to work. That goes without saying. He or she has a desire to rest. He cannot be productive. In fact, not only does he require rest, but he may also require help from someone. A sick day, if you please, for a significant other. Can persons who are not experiencing a state of optimal health or wellness contribute significantly to generating revenue in a country? We've all discussed it and we've all heard no. Additionally, to not being able to produce, persons who do not function optimally, be it short term, for example COVID, or longer term, like NCDs, would need time to seek medical advice and to do complementary testing and in some cases attend to the rehabilitative services. As suggested previously, not only is that individual unable to contribute significantly by way of work, he or she also will likely spend out-of-pocket revenue to purchase pharmaceuticals. And this undoubtedly has negative economic impacts on his or her family. There we have it again. This scenario is common in cases of stroke, chronic kidney failure, and heart failure patients, to name a few. In 2019, the World Health Organization Global Health estimated that the top causes of disability-adjusted years were neonatal conditions, ischemic heart disease, and cerebrovascular accidents or strokes. We all know someone who has had a stroke. For the past decade, as I said previously, the leading causes of mortality in St. Lucia are cardiovascular diseases and cancers. And of course, their risk factors are on the rise. Given the low rate of personal insurance, we're actually less than 18% of our population in terms of personal private insurance. Most payments are out of pocket. Despite the government's exorbitant expenditure on health, for example, just on anti-diabetic drugs, the government would have paid in 2019, paid out $830,000. And those drugs are free, so that means the patients did not contribute to getting those drugs. But although those drugs are free, the downside is that some patients actually struggle to pay for the already subsidized antihypertensive drugs. And that comes to $488,000, almost $489,000 if you add the $639. So chronic diseases would lead to a loss of the ability to work. But that also impacts significantly on our breadwinners, and it drives our families into poverty, and of course, with socio-economic impacts, negative socio-economic impacts on the wider society. In some cases, and I think Dr. King alluded to that, in some cases, The loss of income due to an NCD has affected the ability of the children in the household to gain adequate levels of education. Yes, Dr. King did mention that. Particularly tertiary levels of education. And this has led to lower economic possibilities for those children. A healthy population contributes to economic growth, and unfortunately, NCDs contribute to decreased productivity and decreased economic growth. Thank you.
Thank you very much, Dr. Sear, for bringing to the fore the importance of a need for discourse on non-communicable diseases and the impact of this chronic condition in our society and its impact on health. I would now want to engage our panelists with questions from the floor. I will ask to be queued at this moment in terms of whether we have any questions from persons who are joining us virtually, even prior to my going into some questions to generate some additional discussion by our distinguished panelists. Any questions from our live audience?
Is on? I don't really have a question per se, just some comments. I'd like to thank our panelists today. We had a wide range of knowledge, all of whom I've had the pleasure of working with. They're very competent in the field. I'd like to really give kudos to our people in St. Lucia, especially we go back way back as 1997 with the health sector reform, where we looked at many things in terms of universal health coverage and health system reform. Even before it became the sexy word out there, we looked at health as a major influence on our productivity and our economic growth, where we said when people are healthy, they can be productive in their daily activities. Productive lifestyles can convert into better standards of living for people and more prosperous economy, which was, I took that quote from the Health Sector Reform White Paper, which Dr. King chaired. So I'd like to say I am very proud of our people, that even now the Health Sector Reform Paper is even more relevant now because it covers a whole range of issues being faced now. We look at the issue of quality, the issue of health financing, how do people access health care and not having to pay out of pocket and not having to suffer financial loss as a result, where people don't have to make a choice between health and eating or sending their children to school. I'd like to also commend Nahum, who spoke of the dependency ratio, where we have less people being born and we have a larger elderly population to look after, who basically need more health, they consume more health services at that age, and at that age too, that is when, if they have any private health insurance, it gets cut off. So we have a higher dependency ratio now with a smaller economic base to support that. And even now, I think the COVID-19 pandemic has given us the opportunity to really bring to focus the impact of health on our economic survival, where we have gone to business places who had to cut down on services because many staff members have been out sick with COVID. We have the NIC who are processing a whole lot of sickness benefits claim. So we have all those impacts on our economy, and we have looked at the tourism sector, who was most hard hit, and all the linkage industries. So it has really brought to sharp focus what the impact of health is on our economy. It also has brought to the fore a lot of the weaknesses in our health system, which I always go back to the health sector reform white paper, because it's really relevant now. I still go back to it up until this day. So I'd just like to commend y'all, and I'd like to commend Dr. King, who was also a pioneer in that health sector reform. Thank you.
Thank you very much. And that was Lauren James, Miss Lauren James, the health planner within the corporate planning unit of the Ministry of Health and Wellness. I would go ahead then and engage our panelists with a few questions to richen the discussions. So prior to COVID-19, before COVID-19, and this is why I think that we need, especially in the health sector, we need to begin to think of COVID-19 as an opportunity. Because typically, health was not part of the economic growth discussion. The policy debate around health and the economy was how do we control and contain the cost of healthcare. Even the discussions around universal health care or universal health coverage and the change from care to coverage was really a factor driven by cost, and how do we contain that cost. Our discussions now with COVID-19, when we begin to seek to balance life and livelihoods, has forced health and brought health to the forefront of the discussions on economic development. How do we safely reopen our economies? And so the question now to the floor is, how can we prioritize health, or how could the prioritizing of health in a post-COVID-19 era be used to help rebuild our economies and sustain the position that health has gained since 2020 as part of the discussions around economic development and sustainability?
I think I'll try. That's a big question you've asked, but I think I'll try to answer it this way. First, I'd just go back to something Ms. James said about trusting and being our people, and actually, for want of a better word, bigging up our people for their engagement. And it'll come back to answer the question. When we did health sector reform, when we started health sector reform, what we did not have a set agenda for health when we went out into communities. We went out into communities to find out from communities what was their perception of health and what was their perception of what needed to be done to make their lives better. And that is why that paper, Lauren, is so rich, because that's the wisdom of ordinary people speaking. That is not health experts writing something for people. That is people writing or telling health experts what to write. That is very powerful, but it speaks to what we can learn from COVID-19. Going forward, if you see we implement a truly engaged health system where the community services, what you would like to call primary care, is the front line. It is the place where the health investments are first made, because it is the place where the economy is protected, and indeed the economy grows. So for instance, if we were to contain COVID-19 right out at in the community, contain it from the point of view, as you were saying, give the knowledge to people and households such that the COVID-19 never transmitted. People didn't get sick to the level that they got sick. People did not have to go to hospitals or the grave, because they knew what to do to protect themselves and their families in their homes and in their communities. That is what a system, if we had that engaged kind of healthcare system, that is how we would have responded. Now, COVID-19 is merely a dress rehearsal for pandemics that are yet to come, because they're worse to come. We can almost guarantee that, right? And therefore, we need to learn those lessons from COVID and put these systems in place such that when the next one arrives, we will be truly ready. And you said it before, not to respond during the crisis, but to be prepared. To be prepared prior to the crisis. We need knowledgeable people knowledgeable about what they need to do in their lives to protect themselves from infectious diseases, but also protect themselves from chronic non-communicable disease in terms of lifestyles, their exercise, their nutrition, eating the right foods, and so on and so forth. That is one of the major lessons I think COVID-19 has brought to bear. Now, Nahum, Mr. Jean-Baptiste will remember, and you said that healthcare has always been a containment approach. How do we contain the cost rather than look at how do we invest? Because if I was to tell you, you could get a 10 times return on your dollars if you invest this, would you invest $1 or would you invest 100 if you can get a 10 times return? You would invest 100 because you get a 10 time return. Why would I go for $10 when I can get $1,000? That is health. Now, when HIV/AIDS hit the world, Nahum will remember, the reason World Bank got involved was not because HIV was a disease, but HIV was a disease that was hitting the economy. Then they learned that the disease and people's health impacts their productivity, impacts the economy, and must be addressed. HIV/AIDS was actually the forerunner of diseases that changed, I think, the rhetoric in the very World Bank that I can remember when I came to St. Lucia as a pathologist in 1989. The World Bank was talking about restricting costs. How do we contain costs? How do we get people to pay for health services? So governments should get out of the business of providing health services for people. People should pay for their own health services, right? Not understanding until after HIV and AIDS that that's not the right approach. And that is why we got to this whole conversation about universal health care and saying we need a system that is fully funded, fully financed, that allows people the investment to be made in the health services such that we get a return not only to individuals, but to the entire country, the entire economy. Health and education, Lydia, to me, the most important pillars upon which a society grows, builds, and develops. And both of those limbs have to be fully invested in if you want the country to go anywhere.
Thank you very much, Dr. King, and for reminding us that if we're looking at returns on investment and we need to position health as a driver for economic development, that there is a need for investment in health. And you'd made that point earlier with regards, and I'd made a note, investment at the personal level. So me as an individual investing in my health, and as a result investing in my wealth, but also at a national level, that government's investing in the health of its population and therefore in the wealth of its economy and the wealth of it as a nation. And so I'm going to hand that same question in terms of how do we prioritize health, or how could the prioritizing of health rebuild economies, to our health economist on the floor, Dr. Lapis.
Okay, thank you. And that question speaks to responsibility as well, because even as individuals, we are not only consumers of healthcare services, we are also producers of health, and it's following on the point that was made by Dr. King. So it is not really a passive, the involvement of individuals and human capital. It's not just a passive thing that we go to healthcare and we get our services. We are also producers of healthcare, of health. And that means one of the critical things is behavior change and how we get that to work. And that is one of the more challenging parts of health and providing services, because yes, why people spend on health, we may spend more on providing healthcare services, but the returns that we are getting are not only dependent on how much is spent, but the way in which it's spent and the responsiveness of the health system to organize itself in a way that we can maximize the benefits. So it's not simply a matter of quantum in terms of what we spend, but in terms of how we arrange ourselves to be able to maximize those benefits. So I think that when we look at that whole issue of health and look at productivity and wellness and how we can ascertain the way to go, it is on the ground. It's really a complicated thing in the sense that, for example, with COVID and so forth, when people see an immediate threat to them by COVID, the behavior basically steps in line. When we think about the existing concern that we have with NCDs and so, because some of the outputs, so some of the effects of the NCDs are not as immediately threatening as COVID-19, for example. The issue of behavior change is one of critical importance. So I think in terms of prioritizing health policymakers, decision makers, community workers, we have to find a way to make those behavior changes as urgent as we have with COVID-19. And I think when we talk about the synergies, one of the things that COVID has presented opportunities for us in that the way we do certain things, we don't see ourselves going completely back to pre-COVID days. For example, I'm here participating in this discussion. We look at things differently, we may be doing things differently. And I think in terms of prioritizing, we want to find out what are some of those spillover effects that we have gotten from COVID, some of the benefits, if I must say, in terms of the way we do things, and translate that into other parts of the health sector delivery system, and in terms of how we engage our community to address health concerns.
Thank you very much for that, Dr. Lapis. There is a question now from the floor, the virtual space. There is a question from the floor. We'll take that while we queue in the question from the virtual space.
Good afternoon, everyone. Thank you for this very insightful and interesting presentation. I'm quite happy that Dr. King mentioned human capital. And I think human capital, or having an optimal level of human capital in your healthcare system, is essential in ensuring that we deliver effective healthcare services and ensuring that there is productivity within our hospitals and even health centers. And I read the Gazette and I read newspaper clippings and listen to the news, and I've realized that there has been a high level of outmigration of our nurses and even doctors. And so in the whole realm of healthcare reform, I would like to know whether this gap is being taken care of. And I know that we have had, this assistance in terms of getting health professionals to come in from Cuba, but how much of a cost it is to the government, and would it be a better recommendation to offer scholarships to our students to, explore healthcare careers, so that, we take care of this gap? Is there anything being done to address this very important gap? And I think that, it's like you see it, you go to the hospitals, you see that the nurses and the doctors are overwhelmed. And I always ask myself, are we really thinking forward, and are we addressing this gap?
Thank you very much for, and I'm particularly delighted by that question in terms of the strain that migration of highly skilled technical workers has placed on the health system strengthening efforts for us at a national level. And would now open that question, put that question out to the floor in terms of our panelists and who would want to take the first volley at a response.
I want to say I really enjoyed that question. I think it's very important. You're actually taking the human capital into another area, which is healthcare, and the human capital for health. And I think it's very important. Okay, speaking as a healthcare worker, the reward in many people go into health as a vocation. You go in to get the monetary, yes, but the non-monetary is probably as important, if not more important. So appreciation of healthcare workers. So when you look at the migration and loss of healthcare workers, you have to look at two factors. There's a monetary side and there's the appreciative side. And I think if you truly examine our system, you will see that appreciation of healthcare workers is not where it should be. And that is part of a systemic problem in my view, in that if you see we had a system that was very supportive, well organized, and Dr. Laptis mentioned it nicely in terms of not only the quantum you spend, but where you spend. In other words, have a well-structured system with great teams, supportive of each other from communities right up to hospitals, with good communication, good social capital within the health sector, good camaraderie, in other words. You would find that you'd have far more appreciation for one another and the work that we do. And that would go a long way towards retaining. But you also question there are gaps, and what are we doing about those gaps? And clearly, I do not know that we have plans, so somebody else can answer that question. But if I had to say what is possible, there are two scenarios. One, organize your health system so that you can make maximum use of the resources, the human resources that you have. Deploy them in the teams and the manners and the spaces where they work best. And in that same vein, remember, as I was saying before, investing in primary care, keeping people well and away from hospitals is very cost effective and less resource intensive, okay? But there's another thing, training. We have a Sir Arthur Lewis Community College. Training. We have unemployed young people. Why aren't we in the abundance of water? Why are we thirsty? Right? Go to your young people, bring them into training. Let us find novel ways of training. In days gone by, we used to train on the job in a vocational way. Nurses used to be in the hospitals, training in the hospitals. So they were actually working while training. We can revisit various models of training which do a variety of things, which can meet a gap as well as for both a short, medium, and long term. But it's going to require a way of thinking, it's going to require innovation and certain creativity. And that is what I think your question begs. Can we do that?
Thank you very much, Dr. King, for that response, and for also highlighting the need that when we speak to training of a need to look at long term, but also looking at the short term and medium term, and being innovative in our approach. And I've made and highlighted the word innovation because I'd want to be able for us to come back to that as a discussion with regards to innovation in healthcare. And I see that we have positioned at the mic already an individual with a question, so we'll go ahead and open up to the floor.
So Glenn Simon, National Competitiveness and Productivity Council. In terms of management of healthcare and healthcare facilities, I think you've had a lot of hue and cry from the public indicating that they're not getting the care that they would like from our facilities. And as important as healthcare is, we have our healthcare institutions that you have a brand new hospital with OKEU. Our radiology unit is still not up and running in the way it should be, and we have one of the most state-of-the-art pieces of equipment. You have a lot of facilities within the hospital that private facilities seem to be doing better than us. Is it that there is a management issue that has to be addressed and we have to admit to it, whether we have the capabilities to do it and to run our hospital? We have a new hospital supposed to be coming on stream as well in St. Jude. How are we going to address our healthcare issues in terms of the management of healthcare, which is probably something that we may not have touched properly here, but how do we do this in a satisfactory manner that will reduce the complaints that you hear from the public? You have the private institutions being able to offer radiology services for a long time, and government still has to pay for services from private facilities in order to have care administered to their patients. But how can we utilize more of government resources, make it cheaper for persons? We talk about healthcare financing, and probably this is one of the ways to reduce the cost if more of the services could be available in the private care. Is there an issue with healthcare and the management of healthcare in St. Lucia? I know, Nahum, you've been in there for a while. I'm not sure if you want to start off.
I talk a lot, Lydia. So
I know, Dr. King, I am thinking, though, that this seemed to have been a question that was crafted in such a way that it catered to your expertise. One, in terms of where you sit in the private sector, but also, just as importantly, the significant contributions that you've made to the public sector and your understanding. And I think if we look at our panel, maybe the individual with the greatest expertise in terms of the understanding of the need for public private sector partnerships in health, and addressing this question in terms of where we are at now with regards to healthcare management, and whether or not it's a management issue in the public sector when we look at what's happening in the private sector.
It is, and let me explain. I've worked many years in both. So this is my understanding of it. The problem, the thing, best management comes from empowered teams working together with clear goals, objectives, and understanding of what they're supposed to deliver. What has happened, private sector automatically tends to go there, and private sector, there's no magic about private sector. The thing about the private sector is that the team knows that for them to thrive or survive, they need to work together to produce products or services that people will purchase, right? Therefore, for instance, I run a private laboratory. So me and my management team, we sit all the time, and we are constantly looking at how we can improve our services, get more equipment, keep our equipment running, keep our doors open, extend our hours, get more people, how we can bring costs down, how we can market here and market there. That's private sector thinking. Now let's flip. When I was sitting in the Ezra Long laboratory, how do we end up now? We have to write a new initiative, send it down through the Ministry of Health. Then it has to go to the Ministry of Finance, assuming it gets through the Ministry of Health. It then has to go to the Ministry of Finance, who then makes a decision. The problem, I think, with the public sector is the decision-making is too far away from the point of action. Now, therefore, when we're talking about UHC, we're talking about integrated but decentralized. And decentralized means the decentralization of power as well. So in other words, I hire you to run the radiology facility at OKEU. I empower you to make those decisions and for the service to be up and running and delivered. Now, we tried to get to that by creating a board of the hospital so we could have we could devolve authority to the board. Now, Dr. Laptis, I keep on getting your name wrong, Doc, forgive me. Laptis, Dr. Laptis. Dr. Laptis, let me tell you, you in Trinidad have had lots of experience at various health reforms of trying to take governance into, in that way, boards and health authorities and so on, right? And we are not achieving as we could or should. And I think a lot of it, like all things, it's thinking. It's a way of thinking. And government needs to start thinking. Let me put it this way. When I was CMO, I used to tell my team, I don't look to the Ministry of Finance, I look to the public. Because my job is to provide services or ensure that services are there for the public. The Ministry of Finance, to me, is a resource for me to do that. The Ministry of Finance is not my boss. The Ministry of Finance is my servant, because I am on the front line and I am telling the Ministry of Finance, for me to do this, for you to achieve in this country, we need to do this. Back to the whole issue of where we invest. Now, if that is truly your mindset, then you would begin to achieve what you're talking about. Our public management would then begin to do what it is supposed to do. You with me?
So there is a management issue in
Big
terms
management
of
issue.
the bureaucracy in public sector is preventing proper healthcare service to be delivered. From what I'm summarizing from what you say.
Well, yes, I think it is so. I think because it is almost like serving two masters. You find, as healthcare workers, you find yourself in the public sector serving two masters. You're serving the public authorities that are demanding certain things, and you're trying to serve the patients.
So, Doc, then how do we fix this? What is will a board work as is being done now? Will a board work? But I guess the board is only in one institution. It's not all around, because it's not a board that runs the healthcare for all of St. Lucia. So how do we prevent this? Because I do understand what you're saying. Private care could actually purchase something if they need. You need an X-ray machine, you see how it impacts your service, and you could purchase it. Government operates differently. As you said, a new initiative. So is that going to be a perennial issue for us?
It will, until such time as we are prepared to change our systems of governance and the bureaucracy with a clear understanding. You see, if we were all aligned with clear objectives and clear goals and clear understandings as to accountability within the system, because it's really down to the public sector is concerned with, everybody is concerned with accountability, in fact, public and private. But the systems of accountability do not have to remain this old, entrenched, colonial-style accountability systems where the financer is the one that is the controller. To me, these are colonial hangovers that should be gotten rid of. I fully agree. A nurse in a health center must be accountable for the monies that are spent in that health center. But on the other hand, she must be given that free hand to design her services and deliver those services, making her demands within a budget or whatever it is, however you've decided. It's a budget you've set, she must deliver within that budget, within the types of services. And then, of course, we renegotiate as we move along. But the freedom to manage the services is what I'm talking about. And the public sector must begin to debate how is it going to create freedoms for people to manage while maintaining accountability of public resources. That is what that's what the public sector has to debate.
Thank you very much.
Thank you very much for that response, Dr. King, and highlighting the importance of healthcare reform, taking into consideration the changes that need to be made with regards to its governance, not only its financing model, but also its governance model, and the importance for the decision-making to be closer to the point where it has greatest impact. And I think I would want to redirect part of that question to Mr. Jean-Baptiste, especially in his current capacity as the coordinator for the performance-based financing project that sits within the health system reform project of the Ministry of Health.
Yeah, I think I want to concur with Dr. King throughout, and I've been listening to everybody. But I think the problem we have now is that most of our financing is input-based rather than, if you want to call it, output or performance-based. So in other words, even if we let's look at how do we come up with the budget for anything. You know, do we match the budget to outcomes, or do we match it? I'm not even going outcomes yet, to outputs. I want to posit that it's based on inputs. So that's where the change has to come. It has to come, we have to get into the mindset of moving from thinking about the equipment and thinking about what we need to do to get the output, to trying to match the finance and the efforts to the outputs and the outcomes. So that takes a whole change, a whole shift in how we budget. So we are in that quandary because as health professionals are not really interested in financial things. You know, I could tell you, even we had a challenge with the HIV program that Dr. King is talking about, and what it taught us in health is that we have to think strategically. We don't have a money tree, and so we were forced by some of the documentation that we had to do to think strategically, come up with a strategic plan, and then for every cent in there, you had to match it to an output. So unless we move like that across, it will take time because, for example, we have to sensitize and make finance understand what are the important outcomes in health. I'm not sure that finance has that. I'm not sure. I'm not sure because I've not really been part of the budget process. But I know that under health, there are certain performance-based outcomes that we must deliver to ensure health and wellness to our population. The challenge is how we cost that. And the challenge is when we cost it in health, whether it's consistent with the budget that finance has for us or whether it's linked to the budget that finance has for us. So I think that is the first step, you know, bring in the minister. I don't know how, I'm talking about the what, but the how might be where the challenge is. Now, I know that finance, some time ago, we started with some of the outcomes. I remember as part of a department in the Ministry of Health, we had to link it to link our outcomes to those, so that we can get a cost on it. But I want to say that even within the health sector, that is a skill. Because a skill in monitoring and evaluation, that is a skill that is required to take the development of your budget from the bottom and come up. And then that way, you'd be able to have to do a lot more management of your outcomes, management of your program, management of the resources. For example, why is it that we still have, after 20 years, more than 20 years, two or 3 decades, we still have a brain drain? You know, I mean, do we know what's contributing to that? I mean, what are the things that we have to tackle to make all of these things? The fact of linking your outcomes or your outputs to the budget and to your efforts rather than inputs. So generally, in a nutshell, that's how I'm going to put it. And I think this has been the Achilles heel of our response in health.
Thank you very much. And so I'm going to prepare our panelists at this point in time for us to wind down. And so we would do just 2 last questions. Mr. Jean-Baptiste, I think it would be remiss of us for us to conclude today's discussions without coming back to how it is that we first started in terms of setting the stage as it relates to the demography and the role of demography in terms of positioning in understanding health, as well as how it is that we can use the demography to help us as we pivot health during this critical stage of discussions on health as an economic driver. And I would want to, I've often thought, and I have said it in a few forums, that your success on the HIV project may very well have contributed to the change that we've seen in terms of our population, because part of the behavior changes required as we responded to HIV as a sexually transmitted infection may have resulted in fewer births. How do we begin to address this, or what would be the recommendations as a medical demographer? What would be the recommendations to address that demographic shift where we're seeing an increasing aging population, but the implications of a narrowing or the implications of fewer births and the implications it would have on our workforce in the next 15, 20 years? How do we begin, as part of the economic discussion for health, how do we begin to have that discussion around the demographic shift? Yeah, thanks for that question. Not that I can answer it effectively, but but it's a very good question. And one of the things I will tell you is that once fertility starts to decline, we are going to be in that situation of fertility decline,
Because I think our replacement level is about 1.5, 1.4, 1.5, and it has to be at 2.1 to be able to replace our population. So what should be our response? We are not going to get as many children as we got in the past. What we have to do is to improve the quality of those children, so to speak. So we have to reduce on our premature births. We have to reduce on children who die. In other words, focus more on our maternal and child health so that we have more quality, less and more quality children. In terms of education, we definitely cannot be continuing building schools. We now have to think about the quality of the education. So we have less people. We now are moving from a quantity in terms of the birth, less person. So let us now go more, take education to another level. Take education locally. I know we have been trying it in terms of the campuses and so on, but we need more creative thinking so that, for example, it will not take so much effort on our young people, people now to, let's say, get a degree or get something towards a degree. We have to think along those lines because of the fact that we have less children now. In terms of the chronic non-communicable disease for the elderly population, and I'm dealing with those because those are the two, if you wanted, the two dependents in the population, the children and the elderly. We have to reshape our response to that. I think Dr. King mentioned a focus on the primary care. We have to, because we will not be able in the future to think about addressing all of our most important response being hospitals. It's going to run us broke. It's going to run us broke. So we now have to strengthen our health systems by introducing a much more robust and stronger non-NCD program in primary care. In primary care, that's where it happens. And then, of course, we have to continue with trying to, and COVID has shown us that even if you're tackling the COVID epidemic, look at the persons who it's affecting the most. The persons with the chronic disease, they're the ones most impacted by this. I mean, more than 90% of the deaths we have a chronic disease. So we cannot, what we shouldn't do is during the season of COVID, do COVID. During the season of dengue, do dengue. We should have a resilient system that goes across and looks at it all. And that is how I'm going to posit it. We need to think a lot more strategic. We must have this, people talk about 5-year strategic plan, but I think a 10-year strategic plan, looking at what are the main priority areas for us, thinking about providing health during the life cycle. And that way, I think we'll stand a better chance because Dr. King is right. We're going to have re-emerging communicable disease. Even if it's not part of a major part of the mortality picture, it's definitely going to be a major part of the morbidity picture. And as we have seen with COVID, affecting our economies. Yeah.
Thank you very much for that, Mr. Jebatteson, reminding us of the need for us to begin to speak to resilience in health. And I'm going to invite our panelists now to offer their last words. And I'll start off with you, Dr. Sear, and maybe you want to, in some way, cue your response with a question that we have. Mr. Jebatteson would have alluded to it in terms of the significant impact that COVID-19 has had on people with underlying health conditions like chronic conditions such as diabetes, hypertension, and other chronic diseases. And looking at what we have learned today as part of the COVID-19, in this COVID-19 era, how can we improve the health of our population to build resistance against future pandemics, to continue to position health for economic growth and development? And so I would leave that question with you for your response and the closing remarks, and then hand over to Dr. King, and coming full circle to our economist, Dr. Lapis.
Okay, good afternoon again. Thank you so much, Ms. Atkins. I love the question. As Dr. Lapis was talking, I noted something that she said, and she said we need to rethink healthcare. One of the quotes that I've come across I like quotes, I like proverbs. It says, thorough preparation makes for its own luck. And I think the COVID pandemic has proven that to us. We met with COVID, we were largely unprepared. There were lots of things we learned along the way. And I always like to take the positive side of things. So although there's a lot of negative to the COVID pandemic, undoubtedly so, I believe there are things that we have learned. We've learned to rethink healthcare, we've learned to be prepared. One of the most important things I think that has to do with COVID and with NCD prevention/control and survival, if you want to say that as well, is that we need to make sure that our patients are educated. We need to ensure that the management of chronic diseases is not in the physician's pocket or in his head, but that the management becomes part of what the client himself is aware of, and so that the physician and the client become partners. And I think COVID-19 taught us that the patient needs to have that information, that as healthcare providers, as policymakers, we ensure that we target the health belief of our population. Of course, we know that in fact for the vaccination, the vaccination hesitancy, a lot of that has to do with the health beliefs. And if we don't get through to the health beliefs, we cannot make a change. So we've learned that as policymakers through COVID. We've also learned, and Dr. Lapis made mention of that, we've learned that we can't continue doing things the way we used to do them. Everything was face to face. We've now learned that health needs to take advantage of social media, put that information out there, and ensure that we're targeting those we need to target. The things that we have done as a ministry, we've really run forward with our self-management of chronic diseases through our Bureau of Health Education, through our nurses, and we're trying to get persons on top of managing their diseases and on top of having patient education. We've sent out booklets, chronic care passports, where they have the information with them in a colorful form, and they could log in their blood pressures, blood sugars, etc. They know how often they need to visit the doctor and so on. And I think all of that helps with managing and having education. I think there's a lot that COVID has taught us as well in terms of risk factors, highlighting our risk factors. One of the things that we are targeting, and we will have to continue to target, is the rise in obesity. Of course, because of the pandemic, persons were very sedentary, including our children. Already we had an issue with child obesity, and that we believe has worsened. So that is one of the things we want to get into our education system, in our health curricula, to target things like childhood obesity, etc., what our children are eating and so on. I think largely we need to change how we do things, and I think we have learned a lot from COVID in that sense, and moving forward we just need to continue fighting and making sure that we're prepared for whatever else comes. Thank you.
Thank you very much, Dr. Sear. Dr. King.
I think taking off from really what Dr. Sear Philbert said and what Dr. Laptis said, I think it's very important that partnership and genuine, honest, truthful engagement be the way forward. We have a wonderful opportunity in health because we are really about wellness and good. And that should be easy platform to engage every single resident in the country as, Dr. Lapie said, not only a consumer of health services, but a producer of health. Recognizing people as primary producers of their own health and empowering them in a framework where they are educated, informed, and engaged, and we with them, would be a wonderful way to move forward with health sort of leading the way as to what national unity, a national response to various health challenges that are facing all of us, how powerful that can truly be. And I think in health we have that great opportunity. We saw in COVID that if we don't engage, we're going to be in trouble, right? So clearly, a big lesson is really, I like true engagement. I like the whole concept of the democratization of social media and information has made it imperative that we in health use that media in an innovative, creative way to engage people in what is the right and correct way forward. So I think going forward, if we refocus, and we don't, as healthcare providers, we don't see ourselves as the experts prescribing and treating people, but rather we see ourselves as the engagers of a certain repository of information and knowledge and guidance, and we are engaging people to help them to develop or achieve a quality of life through their own life choices. I think that would be the way I would love to see the health system develop, and I think we can do it. But we're going to have to break some of our old thinking and be very creative and innovative going forward.
Thank you very much, Dr. King. And now over to you, Dr. Lapis.
Okay, thank you. And I believe it was the WHO that mentioned that health is not only the absence of wellness, but how we engage people into maximizing their potential over the whole life cycle. And I think it's important too that even when we have our populations to engage in a holistic way in which we're not only focusing about the absence of illness, but to make that fusion, and it means then that we would have that holistic thing, not only from a Ministry of Health per se, but working in co with our different ministries, with social sector issues and so to focus on that holistic approach in terms of how people use their potential to contribute to their own welfare and for the welfare of the nation as a whole. And I think that is as a whole. And I think that is important. I think that COVID-19 has presented us with many opportunities, which I hope in each of our countries in the region that we are able to look at those and leapfrog in some ways in terms of how we do things in the health sector. And I just want to close by wishing you in St. Lucia all the best, and thank you for your invitation.
Thank you very much, Dr. Lapis. And so we started our discussions today, and we were promised a rich and engaging and thought-provoking discussion. And I would like to thank our esteemed panelists for delivering on just that. They were an incredibly powerful panel who've been very frank in the discussions, and they've raised the issues in terms of how different sectors, private sector, public sector, academia, can work together with health system strengthening, and the importance of the underground analysis and its need both in terms of the successes for health system strengthening, but also in terms of understanding the challenges for achieving those goals. And I think one of the thoughts that kept playing through my mind throughout the presentation and our discussion is that it is good for us to have these nice agreements and to have these nice discussions and the policies, yet the real action is what happens on the ground, and how we can take this discussion that we're having here today and to have it actioned on the ground where we can see real change and begin and advance, not begin because the discussion is already happening, but advance this discussion in terms of how it is that we can continue as a nation, as a region, as individuals, as the purchasers and producers of health, how we can continue the discourse on pivoting the health sector as a primary and important sector in the discussions around national productivity and economic growth. Wish to thank you for your participation in today's discussions, and to the individuals on the floor for your rich and engaging questions to the panelists. Thank you.